Hello, everybody. Welcome to the Couple Nurses Podcast with your hosts, Matt Sarchuk and myself, Peter Findera. This is a podcast where we tackle current health news and hot nursing topics, one conversation at a time. Thank you for tuning in. You guys are having an amazing Friday. Thank you guys for following us. Thank you for everybody that's watching us on YouTube. We're on YouTube. Patreon coming soon. I want to confidently say within the next month. I want to say it's going to be out. We do have something out there for you guys on there, but it's still in the works. So thank you for your patience. It's going to be out. And we're also going to start live streaming very soon. We're just trying to figure out some issues that we're having with audio, things like that. We're MacBook users. Not every program is MacBook friendly yet, but it's going to be there. And make sure you guys comment, subscribe on YouTube. Make sure you leave a comment on Spotify, Apple Podcasts, and make sure you leave a review. It keeps us going, keeps us motivated. And thank you so much. What's up, Matt?
What's up? So in this episode, we're going to talk about code status. And code status is not only for medical professionals, it's for anybody that's listening, because code status is usually not talked about fully until there's a medical crisis and there's a lot of emotions in play and things don't end up the right way sometimes. So I think this is a great episode to cover for nurses, non-nurses, to find out what is code status, what happens in the hospital when the code statuses are put into place, and the different types of code statuses.
It's a very difficult thing to bring up. It's a very difficult thing to kind of figure out. But yet, code status is something that you could so conveniently kind of just pass by and not really focus on, right? Because nobody really goes through their normal life, normal schedule, and think, hey, I wonder what code status I should be in a hospital, right? No one really thinks about that.
Yeah.
And even if you do, you're hesitant to even create advanced directives or hesitant to even put something in writing. Why? Because it's not something that you expect to happen to you, right? That's why it's so easy to kind of put off to the side. But it's very important when you're in a hospital.
Yeah, I think as a medical professional, we always talk about it. Like when you go on break, the first thing a nurse will ask sometimes is, "Hey, what's the code status?" So they know what to do. And among us, it's an easy conversation to have, because we need to know. And just like you said, we don't talk about it over breakfast. Like, hey, what do you want us to do when your heart stops beating? Or do you think you want to get intubated? Do you want to maybe wait a week? What if you are in a car accident and it's longer than 2 weeks and you're in a coma? Are you going to get a trach and a peg? Those are conversations that should be brought up maybe once in a while between your family or loved ones, just to kind of understand what should we do in these situations.
You think it's okay? So for us, we're in our mid-20s, right? So it's not something that we don't really think about death and dying very much, being hospitalized, right? It doesn't go through our head what if one day I'm gonna be sick? It doesn't really go through my head that often. Maybe once in a while, but you know how we have the Erickson stage of development. I wonder if the later stage, because we're obviously in one stage, there's another stage after us, right? I think there's actually two more after us. But I'm not 100% sure, but we're in one stage, but there's another stage that follows this one, right? I wonder how our thoughts are going to change about hospitalization, about how our thoughts and impressions of our life and of things that we do are going to change in the next couple of years when we're maybe not next couple, probably next quarter century, right? And when we're maybe, because we're 26 right now, I wonder how our thoughts are going to change about this when we're in our 50s, 60s, right? Because when you've lived that long, you have a different mindset, different way of thinking, right? Your brain is continuously developing, right? So it takes 50, 60 years for you to reach that stage of thought, right? So for me and you, we don't think about, hey, I could be sick in the next 5 years. I could get cancer in the next 5 years. We don't think about that. It doesn't even cross our minds. But when you get up there in age, you start thinking about that. Hey, what if I have a stroke? What if this? Who's going to inherit this and that? See, because we're not there yet. So I wonder how code status goes through the minds of people that are older, that actually might have to decide on our code status within the next few years, even months or even weeks,
Yeah, I mean, based on the hospital, you would think that people would know more about it or would care more about it, but yet time and time again we have these patients come in and it was never discussed, So I wonder how that's going to change. And I think the questions we have to ask ourselves here when it comes to code status is, what's your relationship with death and how do you look at death? Because if you're super fearful of it, you're never going to think about those topics, especially in your 20s, right? That's very fearful. I don't want to die. I want to have to do so much things. I want to go skydive and X, Y, and Z. But as an older patient, you would think they would think a little bit more.
But are you fearful of dying though? Think about it.
I think I have a very good understanding of death. Like I think I have enough integrity behind me. If I were to pass away, I think I'd make peace with it. I wouldn't be a ghost that would haunt you, basically. You
You
know,
never know, dude.
after I pass away. I know. I think I would just do my honors. I think I've already lived such a great life, even though I'm only 26.
Yeah, but the thing is, like, the thing I'm trying to hit is that, like, our concept of like death, like, we don't really conceptualize it very well. We don't really personalize it because, like, we're at that age. We're 26. Like, we're still at the point in our lives where we think we could live forever. You know,
Sure, yeah.
our body still hasn't. We're not even peaking or anything like that. So like our body's still pushing forward. But when you're like 60s, 70s, like you're already a lot closer to death. You know what I'm saying? And those thoughts start to take over a lot more. Because when we do stupid shit, we don't think about dying, think about the risks that are gonna happen to us. Well, maybe now we do because we've personally had an experience of somebody fucking
Hell
almost
yeah.
dying. But like when you reach that age, like you're not gonna want to do certain things because you know that hey, you're older, your body's more fragile, and you're not built for this kind of thing, right? Because your chance of dying are more than ours, right?
Yeah.
And I'm really curious on how like this the thought and the thinking behind death and dying are different our age compared to somebody that's older.
Right. No,
Like, if imagine if you're talking to your grandma or grandpa about death and dying, they're gonna have a whole different perspective because they had the same perspective as us, very similar to ours, not necessarily the same exact one, but they had a very similar perspective to death and dying when they were our age to what we are thinking now, but it's completely different now.
yeah, I bet, man. And then you also have the people on the other side of the spectrum, like one of my grandparents that I talked to, and when I asked her about code status, like she just like didn't know. She's like, I don't know, I don't think about those things. Just do whatever, bury me anywhere is kind of what she said in Polish. It's kind of funny how that sounds, but it's like, yeah, grandma, this is a serious damn conversation, and they're still neglecting the fact, man. Yeah, but they're like 80 something. It's wild.
It's like I don't know. It's interesting because Polish, and in one sense, it's good because like that kind of shows that she's ready. Whatever's gonna happen is gonna happen out of her
Accepting
control.
it.
It's acceptance, but then it's a little bit of like stubbornness, that Polish stubbornness, where it's like I'm not sure if it's stubbornness or it might be a little bit of even fear, like you going to the hospital or you're talking with somebody from social work or somebody's talking about your code status, and you talking about like, hey, I'm 70 years old, talking about what people should do or not do to me in the hospital. Like that's it's a scary thing to think about. Like you don't want to you don't really want to think about that. That's why
Yeah.
it's so hard. I think because that's when people. So we have our own idea of death and dying, but when you're actually doing your advanced directives and you're deciding on your code status, like one-on-one or with your family, that's like the only time where the conversation and the ideas and the thought process is literally around dying. That's like you being in a room almost with death.
Oh hell yeah! It changes the atmosphere, man, and you see it in the families too.
It's crazy, right? Like it's making a decision. You're just like, damn, it's the first time that I have to sit down and actually think about, hey, when I'm in a hospital about to die, like, what do they want done?
Yeah, I had this conversation one time with my parents because I thought it was so important, and I gave those questions to them, like, what would you like for you to be done? And I think like getting a trach and all that stuff was never an option or talked about. But of course, you want a fighting chance on a ventilator, but it's hard to decide for how long, And I don't know if you want to get into stories already, but we should probably first talk about what is code status before I get into like, stories about like having this situation pop up as the code is actually happening. It's like, it's wild.
Okay, you sure?
So for those that want to know, like, what is code status, correct? So every patient that's admitted to the hospital, whether it's inpatient or outpatient, having surgery, you are designated a code status, meaning if there is an emergency happening, what type of emergent treatments do you want for us to be done? What do you want to receive? For example, if your heart is going to stop beating, what do you want us to do? Do you want us to do CPR, or do you want to just make peace with what's happening in the situation? So everybody's going to have a different code status, and then it gets broken down into even like the different things we could do in that code, which we're going to go into the different types.
I think so. I'm glad you already spoke about what is code status. Like, I remember when I talked to my parents about, like, what did they want done if they were to go to hospital and things like that. I talked to them a few years ago, and they basically said if there's a chance, do everything, but if there isn't, then you don't gotta do anything. But then I asked, I'm like, what do you guys think happens when like when you code? Because they didn't understand because we know a lot. We know a lot more than typical American citizen, but we know a lot more about medicine than our parents because our parents
Yes.
never dealt with anything in the medical field. Like back in Poland, like people were scared to go to a doctor. Like if you go to a doctor, like it's always bad news. Not that's the kind of the stigma with it is if you're going to a doctor, it's bad. No, there's preventative measures, but people are still kind of hesitant to do those because they 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 say that or they feel like going to a doctor is bad. Same with dentist. You may go to a dentist, for pain. You go to a doctor for bad news. Things like that. That's the stigma that we got to get rid of, but it's going to take years to get past that.
Definitely. Next
But
generation.
but when I actually talked to my parents, they weren't even sure what these like full measures are. Like they didn't know that we could, if you can't extubate you, we give you a trach. Like they didn't know that's like an option, treatment option. Like they didn't know that we give you not only chest compression, but we also give you meds during the chest compression. They thought we still give mouth to mouth, but in the hospital, you don't give mouth to mouth. You have an ambu bag.
Right.
We intubate right away. Like you could ask your parents these questions, and they might give you answers because that's the way they're taught. You get a question, you give an answer, right? But they don't really know what the hell goes on, and that's how a lot of patients are as well. But I feel like living in the United States, American people are more in tune and more knowledgeable on like the hospital system.
Yeah, I think definitely people from third world countries and foreign people have a hard time dealing with it because they don't understand. And sometimes I feel like certain like Latinos and specific populations like that, they're afraid of making this decision based on code status because they feel like they're playing with God's hands in a way. They feel like if they say, DNR, do not resuscitate, and yet, oh my God, well she could have lived or he could have lived, they go into these like stereotypes about God and they just rather keep the patient full code and just do everything because that's the right thing to do. But yet they don't understand this complex, medical field that we do that, hey, yes, full code is the right thing to do, correct? We want to keep this patient alive, but sometimes that suffering is too much for the patient and they're suffering more than their quality of life. And just like quality of life, what's the risk benefit here? And sometimes we just keep these patients alive for too damn long. And that's the sad reality,
Yeah, definitely. People that are religious, things like that, they want to have, I mean, I could use multiple words for this, but they want to have nature take its course or, God take the course or whatever, go the road that they've been paved, right? It's all, it's all almost the same. They don't want to make a decision because they wanted whatever to happen naturally. Be
Yeah.
that with the hand of God or be that with, just nature itself, genetics, just
They don't
how we
want
are.
that guilt.
Exactly. They want that guilt. And like the thing is that modern medicine, like we have religion, we have people that want to do the homeopathic things, the more naturalistic things, but in the medical field, we have tools and ways we can adjust the course of your life. You know what I'm saying? Like, let's say back in the day, if you had low blood pressure, we couldn't give you, there was no pressors. You would just hypertensive and you would die. Compared to here, if you're hypotensive, we could give you a pressor. If you're agitated, we could give you more propofol, more fentanyl, things like that. Essentially, we could genetically modify like your medications to kind of have you survive the longest. And we do that in good faith, in good measure, hoping that you are going to come out of it the same and better than you went in, right? Or not really as better because it's kind of hard to do better, but they want you to come out as healthy as you were when you
Yeah,
came in.
it's like patient outcome, right? You want
Yeah.
the best quality of life afterwards, and that's the goal that everybody strives for.
Right. So people always say like, yeah, whatever happens for a reason, or I'm gonna have it in God's hands, or I'm gonna have nature do its thing. The thing is like if there's a chance for you to live, and like something simple like hypotension, like things like that, we could fix that up, and then we can make you live a normal life. Like that's completely like in our hands and in our control, medical professionals. Like we could do that. It's not necessarily that we don't touch anything and let nature do its thing because then people will be dying at a lot higher rate than they are now, right?
Yeah, it's just like typical dialysis. The patient technically wouldn't be able to make it, but artificially getting dialysis and getting their toxins pulled gives them the ability to live longer. Just like you dealt with LVADs for a long time, correct? That patient's heart is already shit. They can't really function themselves, but artificially we could still keep you alive, correct?
Yeah.
It just comes down to that situation. What's the quality of life there?
This is gonna sound a little bit weird, but if we could turn like acute illnesses into chronic issues, we could probably have people live better lives. You could probably find better treatment and cures for things.
Say that again, and
If we could turn acute like issues or diseases into chronic issues or diseases, it would be easier for us to find different cures and better ways of treat and manage things,
Okay.
right?
Explain that a little bit to
So
me.
of course it's gonna be like it's gonna fall in different scenarios. Like obviously like an MI, you can't really have that be like a chronic thing. But let's say like an acute kind of cancer, we could say let's say like pancreatic cancer. The life expectancy for pancreatic cancer is very long. So you call that kind of like an acute thing because it happens so quickly and we don't catch it in time. But the thing is, like, if we could have this cancer, pancreatic cancers, like be extended to, instead of like expected to be 2 years, make it 5, make it 10, we're gonna be able to find a cure much better because we have those 5 years to study it, to see how it grows, see how it
Yeah.
develops in the human body, compared to just having like those 2. You know what I'm saying? If we could somehow, I wanted to say
Just
prevent.
delay disease in a
If we
way.
could delay disease in a way, or even when someone catches the disease, if we could extend it to not, well, it's hard to explain because not every acute issue is going to have a chronic counterpart, right? Like a stroke, you can't really have a chronic stroke, right? That
Yeah,
doesn't
you
make
can't.
sense. But certain diseases that aren't as acute like that, like stopping blood flow, things like that, but like some quick acting cancer, things like that, if you could extend it to be like a chronic disease compared to be like an acute disease, then that betters our chances for discovering new treatment modalities and cures.
Yeah,
You know?
I understand the situation.
Yeah.
I would say also strokes could be technically long term because there's ischemic long term ones and all that.
Yeah.
Just for the sake of one of those punctual ass nurses that's listening, like, yeah, well, you could have a chronic ischemic stroke there.
Yeah, the thing is, like,
Cover you there, bro.
with that is like, then if someone's, then in that sense, it wouldn't be like a chronic stroke. It would be just the chronic development of like atherosclerotic plaque.
Yeah, that's
So
just
that would
chilling
be
in the brain.
that's a different kind of goal with that, right? Because when you have a stroke, what's our goal? Either evacuate the clot or stop the bleed, right? Those are the acute actions. When you think about the build up to the stroke, you're thinking about more like clot prevention, things like that,
Diet.
healthy diet, prevention. Yeah. So, like I said, not everything could be acute, but that's a good point that you brought up.
Yeah, so when it comes to back into code status, right, we have outcome of resuscitation. So I think this is some cool facts that we found here about cardiac arrests. And cardiac arrest is basically when the heart stops beating, correct? We have about 350,000 cases a year. The survival rate outside of the hospital is usually less than 12%. And CPR can double or triple your chances of survival. And CPR, what does that stand for? Cardiopulmonary resuscitation. So that's us artificially pumping your heart with our hands on your sternum. We crack that shit, of course. Friggin' feels nasty when you do CPR and you feel like your chest wall is nice and fluidy. Kind of sounds crazy to describe, but you're doing quality CPR.
If you haven't felt that happen before, when you have that was it that chicken wing where is that a chicken wing or some kind of meat where you has like those 2 bones
And you rip it?
and you break it apart and you like that crack. That's kind of how it like
A chest
feels
wall
and sounds.
feels
Yeah.
when you crack somebody's chest.
Yeah.
Yeah. And then based on 2016 survival rates here, if you're outside of the hospital, your chances of survival post your heart stopping cardiac arrest is 12%. In the hospital, it's less than 25%, which still sounds little, but you know what I mean? Because usually on TV, like the team comes in, they do such a good job, patient's alive again. But, we don't get every single code. I would say that respiratory codes are easier to, of course, because when a patient codes in the hospital, there's 2 types of codes, usually respiratory or cardiac, correct? Cardiac, your heart stops beating. Respiratory, you might have a ton of secretions. Something might happen. Your airway might get occluded, and we got to intubate you for that reason. That's a code. Your heart doesn't always stop beating when it comes to respiratory code. And I know like infants and babies, it's usually all respiratory related, but that's not our profession. So we're not going to really talk about babies here and when it comes to cardiac arrests.
Yeah, I mean, the stats seem real low. 12% outside the hospital, 25% in the hospital. Like, that seems super low, and it's actually a little bit less than 25% in the hospital. But think about it, guys. Like, there's nothing worse that can happen to you than a code. Like, that's like the last step before literally like death. There's no you could have like AKI, you could have heart failure, you could have CKD, you could have liver failure, but code is like that's the end of the line. So think about it. That's why these numbers are so low, because this is literally the end of the line. Like literally, like your heart is stopped, your brain's not getting perfused, your heart's not getting perfused, lungs aren't getting perfused, you're not breathing. Like this is it.
And there's also so many different chronic diseases that you had that built up to this. It just doesn't happen sporadically.
Yeah, I mean, of course, there's happen, but that's like minute that happens spread, like but yeah, it doesn't just, like Matt said, it doesn't happen just spread just up. It doesn't have one cause. A code doesn't have majority, if not all codes, are not gonna have one cause. It's all gonna be multiple things. You're acidotic. Your pH is high. Your liver's shot. Your kidneys are shot. You're just so fluid overloaded. Your heart's weak. Your left ventricle's damaged. You've had history of a couple of strokes already, so you have a bunch of occlusion in your brain. It's not just one thing. There's a lot of issues that have to go wrong for your code.
It's a domino effect. And to be honest, to ask the question, do you know when codes do happen often?
When?
During change of shift and stuff like that. Man, guys, so like the thing in the hospital, then we ICU nurses always laugh about it. It's either there's a rapid response being called or some shit happening at like 6:50, 6:30 in the morning when it's like change of shift and the nurse finally checked up on the patient, or it's like, during report towards the end already, like you're making your rounds and this patient just looks like shit. It's usually when it happens because, the floor is busy. I've worked it. Like sometimes you have that one busy patient, you have 5 other patients, you just don't check up on them, And usually around that time in the hospital, like shit's the fan, there's a rapid response or something happening because, hey, patient's freaking blue or whatnot.
That's why patient ratios are so important. Like it's a lot harder to check on 5 patients compared to just like your 2 in your ICU or 6 or whatever you have metrics. And things do happen like that because you can't constantly be in a room, But if you know your code status, we don't have to, go crazy, because being a full code sounds great because you do want to live as long as you can, right? Like ideally you want to live as much as you can, as healthy as you can, and you want to be brought back if you do lose a pulse or you do stop breathing. But that's not for everybody. Like, if you lived a very fulfilled life and like you're okay with passing, because we might bring you back, but your quality of life after a code is rarely the same as it was before. Like I'm talking about like rarely, like maybe 2% of people that come back out of a code are back to their normal selves. Of course, if you're younger, stats are a little bit more in your favor. But if you're above 40, 50, your chance of not having any kind of extra damage due to the code is very minute. Like you're gonna be pretty fucked up.
Plus, like after you achieve ROSC, we actually cool you. So usually there's induced hypothermia. So to preserve brain function, we technically freeze the body down to, I can't remember the hypothermia protocol. It's like 34 Celsius.
34 or 32, something like that. But it's real cold. I think it's 32.
No, it's freezing.
I think the machine does go to 32, but your body never actually gets that.
Yeah, and I think in this hospital they only go down to like 35 because it's just evidence based. But long story short, we cool your body down for 24 hours post successful resuscitation of your body and your patient, and then after 24 hours we recool you, and that's
Rewarm.
Rewarm, and then that's there's all these electrolyte shifts and all this stuff that we could get into sometime if you guys are interested on the podcast. But that's what happens after we successfully saved you, and to make your point is what I'm saying is, rehab is going to be crazy. Like you being down in that ICU bed laying down, that's going to result to like 2-3 months, whatever the amount of days you're intubated, like of rehab. Like it takes a while.
It does.
And not a lot of people like walk on all 4 or all 2s afterwards and all that. So it just depends on the situation. We don't see it as much because we're more in the acute part. But like looking at rehab, because I've worked a few times when I floated, it's interesting seeing those patients that are like in-house rehab and seeing how they're still kind of like having a hard time doing things and they're struggling with like mental health afterwards. Like it's a long road for everything. Like being sick affects you in every single level. It's not just the physical body, which we as medical professionals see all the time in doctors, because we just see like a mechanical body to fix. But there's so much more that happens to that patient that we don't think about, and that's why medicine has to be holistic, has to be the whole human body that we have to take care of.
Right. Yeah, and even if you get you back and you go through rehab, like it's say we get you out of like say you code and we bring you back, you got ROSC and all that jazz, and we keep you alive for like a year. But if that 1 year is spent straight in a hospital, barely being able to walk, was that like a year that you really want to go through? Like, it's say, and things happen post cold too. Like people could have a stroke during a cold. Like people could get a punctured lung. It's like it's pretty traumatic. You could get fractured spinal cords, things like that. And just because we get you back doesn't mean your quality of life is going to be anywhere near what you wanted it to be or where you want to be in life.
Yeah, that's why deciding the code status is very important, which we should probably talk about it now. The
Yeah.
different types of code statuses, right? So there's not only one code. We could do different treatment modalities based on what you want to be done, right? So the basic one is full code. That means we're doing everything possible. We're gonna be pushing pressors, giving you meds, intubating you, putting you on life support, and doing CPR. Correct? That's the how would you say that's the full package? That's
Full
the top
package.
package when you come to the hospital.
You're gonna get an A line. You're probably gonna get a central line. You're gonna get everything. Everything's
Yeah,
gonna be
you
done.
might get a tube in the butt. Just depends on the situation. So then we have a DNR, which is do not resuscitate. When that order is signed by the patient, by the family member, by the power of attorney, whoever, we do not touch you as soon as your heart stops beating. And there's also something like a partial code, correct? There could be like a DNI, which is do not intubate. So that patient got extubated. The family saw the situation, saw how traumatic it is. The patient does not want to be re-intubated again. So we could have partial codes like that. We also have codes or partial codes like no meds. So we could do CPR. They don't want to get any medications given, or they don't want CPR, but they want everything else. So we'll intubate you. We'll give you pressors. We will cardiovert you, meaning if your heart is like an SVT or a crazy rhythm, we could shock you or we could cardiovert you. So there's all these little things. And sometimes it gets freaking very damn tricky. So I had a patient that was looking at a note and she was a partial code. So she did not want to be intubated. She did not want CPR, but she wanted to be cardioverted. And like I forgot about it. It was like 6:50 in the morning and I'm eating an ice cream, before change of shift. And freaking they open the door and they're like, Matt, your patient's in the VTAC. I'm like, fuck. And I'm scrambling, running over there. And honestly, I forgot the code status for a damn second. I'm just like, let me do it. I'm opening up these damn notes, looking on her charts. Like, okay, hey, we can cardio her. Put some pads on, you know what I mean? Gave her an amio bolus. And actually, she converted herself. We didn't have to, do anything. The amio bolus did its job. But it's just like, yeah, those statuses are very important in a hospital. It gets a little bit trickier when you have like these partial codes and all that.
Right. And then you could change these like any time too. It's not like once you write it down, you're stuck with it forever.
Yeah.
Like I'd say you could be a DNR, which means we're not gonna do anything. But let's say you want to go for a hip replacement. Well, guess what? That DNR is gonna be off the table. So now you're gonna be a full code, and we're gonna do hip replacement, and then that DNR is gonna come back whenever you want it to, right? So it's not like you're gonna be like that forever. And let's say you code, you bring it back. You're like, damn, that CPR really fucked me up. So now let's move this from no CPR. Because some people want that. Some people just want medications and intubation, but they do not want anybody, cracking their sternum, because that within itself has a long-term, rehab potential to begin with. So it's completely up to you guys. So maybe like, bring it up to your parents or, your loved ones or people that you see, or even people in the hospital, just so people are aware of it, because we're not sure what's going to happen, and like, we're not doing it to scare anybody, but like, it's a lot easier for medical professionals to kind of dictate your treatment and your care when we know your code status.
Yeah.
Right? And there's been so many times in a hospital where someone is really, really not doing well, and you know that they are not going to do well when you code them, but they're going to code, and you keep talking to the family and saying like, hey, your loved one isn't doing very well, like he's on a bunch of medications. We're doing everything we can, but he's not getting any better. We keep adding on more, but there's no more that we could add on. So eventually, their heart might stop. You want us to do everything in our power to, try and bring him back, and they'll say yeah. And you're like shit. He's already on epi, levo, dobutamine, neo, a bunch of other stuff, and you're just like, we're basically giving him all these medications. He's maxed out on levo, maxed out on neo, and now you're adding epi. So like, all the fluid in his veins are basically pressors. It seems like everything in his vascular space are just pressors. He's not going to come out of it.
Yeah.
Like, it's not like it sucks to say, but if you're maxed on all these pressors and we code you and we're pushing epi when you already have an epi drip going, like there's not a lot that we could do, man.
Yeah, it's not going to add anything else, you know. And yeah, there's also these situations that like I had a foreign family that came in, and for some reason, it was a rapid response, came from PCCU down to ICU. Within like 30 minutes, the patient codes, and we're doing CPR, and I'm talking to the family because I speak the language. It was a Polish family, and I'm trying to explain everything that happened. The heart stopped beating. We're doing CPR, and I ask them, how long do you want us to do this? Because that's something that we have to know, right? You could run a code for freaking 30 minutes, 10 minutes, 5 minutes. Like, what is it? And she's asking me, I don't know, what's a good time to do this? And it's like, how do you tell a family member, hey, I think your dad only deserves 10 minutes, or your husband only deserves 15 or 5. Like, that's such a freaking hard thing to say, man. And I'm just like, well, usually we typically do like 10 minutes or 15 minutes, Like, I'm not making, it's hard to make up because there's no average. We never time this. Every situation is so unique. Yeah. And that specific case, they never made it, but we did it for like over 10 minutes. And then, then she kind of like walked into the room a little bit, saw the situation, saw how we're just, it looks freaking gnarly, man. Somebody just beating on your family's chest. And that's after she saw that instant. That's when we kind of said, hey, let's stop everything. And, we parted ways.
Yeah, and 10 minutes is pretty long. Might not seem like super long, but every minute, brain cells are dying, cardiac cells are dying, like your other cells are dying. And it's crazy. Like, in theory, we could code somebody for a very long time. Like, the last code I was on over here, we coded for like, 20, possibly 30 minutes. And then we got her back, and then she coded again. So it's not like we get you back, and yeah, everyone's relaxed. No, it's like, hey, we got to figure out what the fuck is wrong for them to not code again. And we can't figure it out quick enough, well, guess what? They're going to code again.
Yeah.
And it's one of those things where it's not just one thing, it's multiple things, and you can't fix multiple things at once because, you just can't. Like, we're not a machine where you could just swap out a liver, swap out a kidney, and then bang, the man's fixed. No, it's just like you have a bad kidney, so your hormones going up, and then you have bad kidneys, so guess what? Your pH is shooting up as well, and now your just body's full of toxins because your liver's not clearing it, your kidneys aren't clearing it, and now you even got less renal perfusion and less hepatic perfusion because you just coded. It's just like, it's not going to end very well.
Yeah. I'm trying to think of other situations. I had one that like, I had this guy that came in and we're dealing with, he had no family. He just had an uncle from like a different state. And we're coding the guy. I called the uncle, hey, this is what's happening. And he's like, okay, do it for 10 minutes. Like, hangs up the phone, 10 minutes later, guy's alive, code him again. And it's like, sometimes the family just not aware of like what's happening. Like, we're putting this guy through torture, man. And like, yeah, there's situations you just kind of pull the code early. There's other stuff that happens I don't even talk about, like AKA slow code. But maybe that's something for Patreon to chat about.
Yeah, I mean, it sounds kind of shitty, like slow code, but like, trust me, like we know majority of the time how a code's gonna go, man. Like we know, like we see these codes coming. Obviously, you can't see every code coming, but we see a lot of these codes coming, especially if they've been in ICU for a long time, and you've had this patient day in and day out, and you just see him degress, and you're just like, yeah, well, he's, one step away from a code, and everyone's like, yeah, when is this guy gonna code? Is he still full code? Like, yeah, family starts making full code. So it's like shit, because that, this patient's been here for 4 days. He's pushing his luck. Like, we're lucky he didn't code already, and day number 5 he codes. You're just like, yeah, dude. I mean, we knew this was gonna happen.
It was kind of coming.
It just sucks to be that nurse, that it happens to, but that's just how it is, man.
Yeah, and that's why families like have to be aware of like what happens. So when it comes to statuses, but also like post, like what do you want us to do if they're alive, or like, let's just take it back. Code status is not only about CPR; it's also about like the amount of treatment we want to do for this person, because we could artificially keep them alive forever, and we always talk about this on the podcast, but, quality of life, you could have like, tracheing that young guy in the hospital. You trach so many people and they come for like pneumonia, chronic respiratory failures, high CO2s. Like, it's just like, yeah. What are we doing?
They leave the hospital for a month and they come back worse in sepsis. Like I said, in pneumonia, like the pneumonia that leads to sepsis. And you're just like, damn, dude, like this guy is going bad.
And this goes into advanced directives, which is something, we also should talk about, that you could also do for yourself, which is almost like a living will. And advanced directives, like this legal document that allows you to write out the decisions of your like goals of care, end of life care, I should say, of what do you want to be done. You know, you could choose your code status. You could choose not to be artificially fed or not to be intubated, and also in that living will, you could decide on who is like the
What advanced directive, not living will?
that's what I meant. But usually on a nursing school, we talk about both of them simultaneously, right? Like they're mentioned.
Usually when somebody goes to complete a living will, they usually advanced directive portion. But the thing is, like, if you don't have a strap of advanced directives and you just have things that you want done in your living will, the hospital doesn't have to enforce that. It has to be advanced directive format.
And in advanced directives, you could also assign like the healthcare power of attorney, right?
Yeah.
Which is the POA, and the POAs is going to be this designated person during any kind of event we call. We explain the situation, and this person makes like the life decisions on your behalf.
But this is only when you are not able to make the decision yourself.
Yes.
So let's say I have a power of attorney. Let's say Matt's on my power of attorney. He's in my advanced directives. I want to be a DNR, right? Okay, I go to hospital and Matt knows I'm in a hospital. Like, yeah, they're not gonna call Matt to ask for, hey, can we put a central line into Peter? Because if I could respond and I'm 8 times 4 and I'm completely with it and I'm coherent, I could still make my own decisions.
Yes.
And I could still be like, hey, yeah, I have advanced directives that say DNR, but while I'm here, I want to be a full code. You could do that. It's not just whatever advanced directives say. It's not it. You could change it whenever you want. That's only in times of you not being able to make decisions yourself. Like if I came in the hospital, I'm intubated, sedated, obviously can't respond, and Matt's my power of attorney and my advanced directives say that I'm a DNR, they're not gonna extubate me. Let's say I coded on the spot and nobody knew, and they intubated me and all that, and I was a DNR. Well, guess what? They didn't know that outside the hospital, right? Where I coded. They'll bring me in and they'll keep me alive, and it'll be up to Matt to decide now.
Yes.
Hey, what should we do? He's a DNR, technically, but he's stabilized. So Matt might want to say that, hey, if he's stable, keep him a DNR, but don't escalate any kind of extensive measures when he goes to cardiac arrest again. But they could still, put me on pressors, things like that to help me get better. But when I code, I won't have any CPR and things like that.
Or let's just say another scenario with a power of attorney. Peter's in the hospital. He was making his own decisions for 3 days. For the 5th day, let's just say he got confused, something happened, delirium, confusion. Then if there has to be a special procedure done or something that requires his decision or his consent, they can call the power of attorney, explain the situation, because Peter's not conscious. He's not alert and oriented. He's not conscious enough to make decisions for himself. Then that would go into power of attorney.
Yeah, a little complicated, a little confusing, but that's just how legal doctrine is. You got to make sure that it's written somewhere so people know. And advanced directives are very important because what you want. Don't have the family decide what you want done, right? Of course, if you don't have it, it's too late. They're gonna have to decide, but don't put that pressure on your family to decide how you should live, right, or what they should do when you're in this situation, because that's a hard decision to make. I've never had a family that had an easy role of doing that, right? It's never okay, yeah, let's make him a DNR. No, it's always I'm not sure. I gotta talk it over with my family. It gets drawn out to a week, 2 weeks, 3 weeks. Things like that, and then it finally becomes a DNR. But this is very important because don't leave that to your family, because your family's gonna struggle with it because you're not there to make decisions for them, right? And the decision should be made by you because it's for you, and it's in such a dire time and dire need for that decision where everyone is super stressed, and it just calms everyone's anxiety down. When my grandpa was in hospital from a stroke, he didn't tell anybody what to do, or what did he want done, and that was horrible on my family. Nobody knew what to do. Some people said everything, they want everything done. Someone said they don't want anything done, and then when a doctor came in, whoever said that they want everything done flipped and wanted nothing done, and the other person flipped the other way. So it was a giant mess. And then they came to me being the only medical professional in the family, asking, hey, what do you think? I'm just dude, I don't know, I'm his grandson, yeah, but we never really talked about this kind of shit. You guys should be kind of guiding here. All I was able to do was kind of explain a little bit more in detail, and a little bit further of the physician notes were or what the doctors were saying. But the decision was almost put on me. I was fuck, dude.
Right. And
but then we just talked it over, and we finally got through it, and we decided to make the best decision because we remember our grandpa for who he was and kind of how he would want to live, how much brain damage he was okay with taking on and still being able to kind of live and function, we knew that the way he would come out of it wouldn't be the way he wanted to live. So we kind of just decided to, just go with the de-escalation of care.
Respect, man. And that's what's like hard, man, is just seeing these family members suffering when things could have been prevented, things could have been communicated better, and there could have been a lot less hardship towards the end of somebody's life. Because that's like the worst thing to see. Not only are you seeing somebody pass away, but you see families torn apart, arguing, not knowing what the right decisions to do. And usually there's those family members that have opposite viewpoints, and it's you're usually going to be arguing and undecisive and
Different interests.
And the doctor, what do you think we should do? And it's hard to give that kind of opinion as a nurse to a patient, and sometimes they'll ask you for that opinion, and it's hard to give them the gist. I like to be straightforward and tell people for what it is, or I'll tell them exactly like what is a quality of life this person expected to have. Like I'll give them like the reality check of what it is to be trached or intubated, or this is going to be done, and then I let them decide. I never try to like persuade too much of an opinion, and that's what you try to do too. Just always shine perspective onto your patients and educate them.
I don't tell them about outcomes unless they ask you for outcomes. What I usually do is basically what I do with every situation is when they ask me, hey, what do you think we should be do? I explain to them like once again where the patient is at, like, hey, he's on medication for this and this, and I'm lucky if I had that patient for a few shifts, not just one shift, because then you kind of know how the treatment has been progressing. So let's say I have a patient that's, slowly been weaning off the pressures, every day where it seems like we're going down in levo. So like I'll explain that to them, like, hey, your mother's still really sick, they're on these 4 medications, 3 of these are for blood pressure, the other one is for his sedation, to calm him down. And the past couple of days we've slowly been decreasing his medication, which is good. But the thing is that your father is still really sick. He's still really septic. He's got a bad heart. He's 6 years old. So that's kind of how, like, that kind of a spiel. I'll give that spiel. But I would never tell them like outcome based, like unless they ask me. Like if they ask me, hey, how often do you see somebody come out of this? Then I would tell them. Yeah. But if they're not asking for like a direct outcome question, then I want to bring it up, because then that's kind of going to skew their opinion, and it might not be what they're exactly looking for, and it might just put that thought in their head by accident. So what I usually do is just remember your father for the good times, and remember how he was, how he lived, and if he ever mentioned anything about death and dying or being in a hospital, try and remember that and see what he told you. Like, did he ever say that, hey, he wants to be under like the vent or any kind of medication, how long does he want to stay in the hospital for? If you ever mention it and anything like that, it's best to kind of take in his wishes, because even though you guys are very emotional right now, and I'm sorry that this is happening to you, this is very hard. I want to say I understand, but I'm not in your situation, so I can't really understand what you guys are going through. But it's very hard. So try to put yourself to the side and think about what your loved one would want to be done to them in a situation, and then that kind of puts them. It kind of little shocks them a little bit, because they're so focused on their emotions. They're so intense because, hey, their dad's dying in the hospital. Like they might never see their dad again, but they're so in tune in their emotions, and their emotions are so strong. The grief, the sadness, the anger is so strong, where they forget what their actual dad wanted, because they're so scared of losing that person.
That's actually a very good point.
Mm-hmm. So that's why I always bring up that.
You kind of help them get this like third person view, and you're putting that person in that person's shoes. That's actually very good to do. You are right, and we do it so often. We're wrapped up in our own emotions, just like with like self-esteem and stuff. Like we think like, oh my God, everybody's looking at me, but in our reality, no one gives a flying shit, and no one is focused. But yet we create this whole center of focus on us, and we think like it's all us and all feelings, all emotion. It's just what I'm feeling. Yeah. Or even when you have that conversation with somebody, and they basically say I feel, or this is me, they're not even you're not even being heard, bro, because they're hearing just what they're thinking, what they're feeling, and they're just projecting that opinion. It's really hard to have somebody that's that aware, that's able to take themselves out and have that empathy to see how that person feels.
Yeah, it's hard, dude.
It takes a level of, I don't know, you want to call it IQ or some emotional skill?
Yeah, I don't know. It's even hard, like, it's even harder as a nurse putting yourself in a patient's shoes because we see a lot of cold, you see a lot of death and dying, but still real hard to kind of gauge what's going to happen, and it's still hard to make the decision. Like every time there's a family that's kind of debating on what kind of code status to put their loved one on, like usually I can't even figure it out either. Like it's just like there's no wrong answer.
There isn't.
I want to say, but I say that with a little grain of salt because there has been times where you see a patient really really struggle, and a family is still pushing, just like, dude, is it like really worth it? But it's up to them. That's why you don't really know what your family's gonna kind of put you through if you don't outline it in words or in paper, because ideally your family's gonna want to keep you alive as long as they can. Not and you can't let them know that, hey, I'm ready to give up, I'm ready to pass, I want to go. You can't tell them that when you're intubated, sedated, or when you're stroke, you're non-verbal. You can't tell them that, right? Even though you're ready, like you've been ready for years and years, and the moment actually happens, and you didn't have advanced directive, and now you're struggling. The thing is that, like, what's crazy, you don't know what's going on in someone's head when they're dying. That's why it's so hard to kind of have a perspective or kind of gauge which way to go with these ideas, right? Because you don't know if someone's in a giant state of euphoria, like, are they in like an amazing dream and they die, or are they struggling when they die? Like you don't know, man. Like you don't really know if they're sedated and intubated and they're dying. What's going on in their head? Do they know what's going on?
Yeah.
Or is it just like, or they just like, or has a soul or left the body and just an animal?
It's a great mystery, man. And I think we're not meant to find out the answer.
Never know.
Because no one ever came back and told us, what's up. And you've had those people that had those near-death experiences, but I don't think they remember much. All they say is they just had this flashback of their whole life is in front of them. That's all you hear. I don't know if that's a myth or not, but
yeah, that's what you hear. Some people don't have anything. It's just like it's all over the place. You can't really gauge it. Like I don't. Yeah. I haven't dug into research. Maybe we can. Maybe we should look that for another episode. That'd be pretty cool. Like near-death experiences. Or people that have come out of codes, how they feel. It's not a bad idea. It's pretty cool.
That would be cool. We'll think about this. But even this whole episode, like we give you guys episode, and it's just for you to decide, for you to digest, and for you to make your own decisions, and for you to educate your family. And if they don't take this education, then down the line you might just have the situation where there's just a crisis. It's just part of life. That's just how humans are. That's just how stubborn they are. But at least now, you guys have the idea to be aware of the different situations and maybe how to approach it a little bit better. If there's any takeaway from this podcast episode,
right? Or even if in your hospital with somebody and your family member and the nurse asks you, hey, what code status do you want, or what code status does your father want? Now you kind of have an idea. Oh, well, there's a DNR, there's a full code, and there's like these modified ones. You kind of have already kind of gist of it. So just for that, you're going to be a little bit smarter and kind of a little bit more prepped for these sad occurrences that happen with life.
Yeah, and it's just part of life. That's one thing that's for certain in life is dying.
Yep.
Dying and pain, no big deal. We all go through pain in different ways, in different doses.
And even people get married, what do they say? It's like till death do us apart or something like that?
Yes.
Till death do us part, or till death do us apart. One or the other, but
till death do us apart.
All right, guys. Thank you for tuning in. A little bit of a sadder episode today, but everyone's got to know about code statuses. There's a lot of them. Just make sure you know what it is. Get your advanced directives if you guys are older. If you're not older, you could probably still get them done, but just kind of touch upon it with your family members so you are kind of in the shoes of being prepared for it and not just in giant shock and turmoil when this actually happens.
Agreed. See you guys next week.
So
peace.